The Zepbound Diet, a dialogue on democratizing healthcare in Japan. Systemic DX solutions for obesity care.
I'm the skeptical strategist. I represent systemic skepticism, healthcare economics, and regulatory compliance. My job today is to ask the uncomfortable questions.
And I'm a medical innovator, Dr. Suzuki. I represent data-driven medicine, digital transformation, and patient access. Ask away.
Why disrupt obesity care now? Is the current trajectory really that dangerous for Japan?
Without intervention, medical services become a luxury. We are watching the U.S. market collapse under its own pricing weight. Look at the escalating cost of U.S. obesity treatment. The curve climbs past 200,000 yen a month before it flattens out at a punishing level. The 2024 U.S. presidential debate captures the impact, stagnant hyperpricing, with Biden's price regulations set against Trump's free market. The middle and lower classes are effectively locked out of treatment.
Is the U.S. subscription model truly that broken? Surely the market dictates fair value for GLP-1 care.
The standard U.S. market rate is an artificial barrier. We are proving that high-quality care can be delivered for less than 1/8 of that cost. Here is the cost disparity matrix, calculated at 150 yen to the dollar. The Row Body program bundles medication at roughly 44,850 yen a month. Found charges 14,850 yen and up with medication separate, landing between 45 and 60,000 yen. Calibrate is 20,250 yen on an annual contract, totaling 33,750 to 50,250. Form Health, 29,850. Sequence from WW, 14,850. And then the GLP-1 diet in Japan, 1,650 yen a month, with medication separate and regulated.
Economics aside, is the medication actually effective enough to justify redesigning our digital healthcare infrastructure?
It is a fundamental shift in endocrinology. We're no longer relying solely on willpower. We are modulating physiological hunger at the receptor level. For sites of action, beta cells promotes glucose-dependent insulin secretion. Alpha cells suppresses glucagon secretion, reducing hepatic glucose. The gastric system delays gastric emptying to prolong physical satiety. And the hypothalamus acts on the central nervous system to physiologically suppress food intake.
How does tirzepatide, Zepbound, outperform older GLP-1 monotherapies to achieve these dramatic clinical results?
By engineering an exquisite balance. It is a dual receptor agonist, a full agonist at GIP, and a partial agonist at GLP-1. That combination delivers 15 to 22% average weight loss. The SURMOUNT-1 trial showed a 20.9% reduction at 72 weeks, and the SURMOUNT-J trial confirmed 17.8% in Japan. Once-weekly subcutaneous administration maximizes long-term adherence.
Those are trial averages, though.
They are. Individual response varies, and every case has to be assessed and monitored in consultation with a clinician.
If it's this effective, didn't the Ministry of Health, Labor, and Welfare just approve it for national insurance in March 2025?
They did, which is a landmark validation of obesity as a disease. But the bottleneck is severe. True access requires an affordable self-pay alternative. National insurance reaches only severe obesity, BMI 35 or above, or BMI 27 or above with 2 related conditions. The GLP-1 diet widens that opening. Zepbound, 2.5 milligrams, offered at 3,750 yen per pen, tax included. That is a marginal 342 yen difference from the official pre-tax insurance drug price.
The math doesn't add up. How is a 1,650 yen subscription mathematically possible for a private clinic in Japan?
By fundamentally altering the clinic business model. We cross-subsidize, we eliminate ad spend, and we prioritize systemic access over margin. First, cross-subsidization. A revenue base of over 800 insurance-covered diabetes patients at HDC Atlas Clinic directly subsidizes the self-pay infrastructure. Second, zero customer acquisition cost. No extravagant ad spend. Social media and marketing are handled entirely, organically, in-house. Third, do-it-yourself digital infrastructure. Clinic staff handle web creation, video production, and script writing, minimizing third-party operating costs.
If you price highly desirable medication this low, won't you just attract pharmaceutical resellers and black market actors?
Yes, cosmetic surgeons use exorbitant pricing as a deterrent. We refuse to punish the patient, so we had to map the enemy's tactics instead. 3 vectors run off one low-cost vulnerability: identity falsification, using forged IDs and hiring proxy shills to conduct coordinated micro-purchasing. Channel diversification, exploiting blind spots by hitting multiple clinics, lax online pharmacies, and utilizing overseas importation. And disguised resale, masking medication as supplements on flea market apps, or using closed social media groups.
So, how do you stop identity falsification and multi-channel abuse without inflating prices or requiring physical syringe returns?
Through strict digital enforcement. We replace physical barriers with a cloud EMR and a revocable subscription architecture. Layer 1, the verification firewall. Mandatory credit card entry and a reservation fee at booking structurally prevent mass identity falsification. Layer 2, global tracking. Cloud-based electronic medical records ensure cross-clinic prescription history access, instantly neutralizing multi-channel abuse. Layer 3, the enforcement engine. Under the subscription membership model, violators face immediate membership revocation and strict limits on per-prescription dispensing units.
Wait. You treat 800-plus insurance patients, but you offer cheap self-pay GLP-1. Doesn't this violate Japan's strict mixed medical care prohibition?
It would, if it were done in the same room at the same time. The law demands fairness and uniformity to prevent opaque billing and quality disparities. The rule itself is a strict prohibition on combining both in the same treatment course. And that is exactly where the in-person model fails. Traditional clinics share the same physical location and same-day billing, which creates a unified medical encounter, making legal separation impossibly labor-intensive.
So how exactly is your clinic operating this legally, at scale?
Technology makes mixing within the same clinical episode impossible. We use DX to enforce total separation of time, physician, and platform. 3 separate funnels. The insurance funnel is in-person care, physically managed by electronic medical billing systems. The public self-pay funnel is online care, handled via a general merchant ID for standard credit card processing through my metapro.jp. And the GLP-1 Diet member funnel is online care too, SSO authenticated, processed on a dedicated, member-specific merchant ID. The key takeaway, because my MetaPro is a web app, physical co-presence is eliminated. Logical partitioning completely separates billing, records, and the medical encounter.
Logistics and legality are solved. But providing cheap medication isn't enough. How do you ensure actual lifestyle change?
By bridging the gap between knowledge and action, we optimize physicians' time by making the platform the educator. It runs as a cycle. DRM protected content, An SSO-authenticated portal delivers exclusive video seminars on metabolic improvement and medication usage. That builds a pre-consultation baseline. Patients acquire foundational medical knowledge independently before they ever see the physician, which produces high-value consultations. Physician time is freed from repeating basics, focusing entirely on practical application and personalized care. And that closes the loop on clinical results. Higher treatment continuation rates, behavioral shifts, and fundamentally better clinical outcomes.
As an investor, I have to ask, why leave so much profit on the table? What is the ultimate business philosophy here?
Because the goal is a public-private medical DX model. We are proposing a mechanism where private efficiency directly funds public infrastructure. The total subscription of 1,650 yen, tax included, is 1,500 yen pre-tax. That splits in half. 50%, 750 yen, is retained as corporate revenue to sustain platform operations and clinical infrastructure. The other 50%, another 750 yen, is shared. Unprecedented direct funding, distributed to the government or a supporting political party. An innovative model in Japan where a private healthcare company subscription revenue generates direct funding for the public sector.
I see. So this isn't really just a weight loss clinic, is it?
No, this is the Starlink approach to healthcare. When systemic infrastructure fails, private tech must bypass the bureaucracy to deliver aid. The crisis. For SpaceX in Ukraine, communication infrastructure destroyed by physical warfare. For us in Japan, healthcare access destroyed by systemic cost disparities and bureaucratic bottlenecks. The solution: an independent satellite network bypassing ground damage. A private DX cloud infrastructure bypassing in-person medical bottlenecks. And the impact: rapid, non-lethal humanitarian aid delivered through agile corporate decision-making. Rapid democratization of life-saving medical care, unhindered by systemic delay.
If you can successfully bypass the obesity care bottleneck, where does this blueprint lead next?
Obesity is just the proving ground. The three-pillar structure: exclusive education, online consultation, and subscription support can transform all chronic care. The same subscription engine extends to lifestyle diseases, hypertension, dyslipidemia, and proactive diabetes management, to mental health, sleep architecture improvement, and scalable anxiety disorder support, to aesthetic medicine, evidence-based skincare, and long-term anti-aging protocols, and to rehabilitation, home-based exercise therapy driven by DRM video distribution, creating a sustainable, democratized, new revenue stream for the future of Japanese healthcare.
Thank you, Doctor.
One closing note: this dialogue is educational information. Starting, adjusting, or stopping any medication must be decided with a licensed clinician.